Before the continuous femoral nerve block is studied, it is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy. The main indication for continuous femoral nerve block is anterior knee surgery, such as anterior cruciate ligament repair and total knee replacement. It is essential to realize that there is a part behind the knee which is supplied by the sciatic nerve and which may still be painful in approximately 20% of patients after total knee replacement. This pain, however, is usually short-lived, and if this bothers the patient, a single injection sciatic nerve block can be performed after confirmation of an intact sciatic nerve in the postoperative period. If the tendon harvest for ACL repair is from the hamstrings, a single injection sciatic nerve block is also additionally needed. Continuous femoral nerve block is also indicated for painful surgery to the ankle joint, such as ankle arthroplasty and triple arthrodesis in combination with a continuous sciatic nerve block. If properly performed, this block will almost always incorporate the lateral cutaneous nerve of the thigh and the obturator nerve, which makes the continuous femoral nerve block a more appropriate option than continuous lumbar plexus block if a careful risk-benefit ratio is calculated. The femoral nerve originates from the second, third, and fourth lumbar roots, and the bones of the lumbar osteotomes of L2, L3, and L4 will be covered if this nerve is blocked. Note that this starts with almost the entire femur and continues down to the medial aspect of the tibia and medial aspect of the foot. The dermatomes of the leg incorporate the skin area supplied by the L2, L3, and L4 dermatomes. Notice again that this goes down to the big toe area. The continuous femoral nerve block almost always involves the lateral cutaneous nerve of the thigh, the obturator nerve, and femoral nerve if the catheter is advanced under nerve stimulator control next to the nerve. In young, fit, healthy male and female patients, there is no or very little brown fat surrounding the femoral nerve, which makes catheter placement in these patients more challenging, and patience is usually required. Almost all local anesthetics and combination of local anesthetic agents have been used for this block, but the preference of this author is to use 15 to 40 milliliters of ropivacaine, 0.5 to 0.75%, as an initial bolus for intraoperative analgesia, and to follow this up with 2 to 10 milliliters per hour continuous infusion of ropivacaine, 0.1 to 0.2%. Patient-controlled boluses of 5 to 10 milliliters every hour is usually sufficient to control breakthrough pain. Quadriceps function can be jeopardized with this block, and most authorities believe that quadriceps function is essential for knee rehabilitation. This has, however, not yet been verified by research, but it may be advisable to use a dilute concentration of ropivacaine, for example, 0.1% or less, to preserve quadriceps function during the postoperative period. Research is ongoing to evaluate buprenorphine in this role. The patient is positioned supine with the foot neutral, neither externally nor internally rotated. After palpation and marking of the femoral artery and the inguinal crease and disinfection of the skin, the area is covered with a sterile fenestrated transparent plastic drape. The skin, subcutaneous tissue, and intended path for the tunneling of the catheter is anesthetized with lidocaine and 1 in 200,000 epinephrine. An insulated 17 or 18 gauge TUI needle is attached to the nerve stimulator, which is set to 1 to 1.5 milliamps, 2 hertz, and 100 to 300 microseconds, and enters the skin 1 sun, the width of the patient's thumb, lateral to the femoral artery, and 1 sun caudad of the inguinal crease. The bevel of the needle points upward, and the needle enters at a cephalad angle of approximately 45 degrees. Notice the 2 pops as the fascia lata and iliaca fascia are penetrated, and notice the cephalad movement of the patella as the femoral nerve is stimulated. The nerve stimulator output is turned down to between 0.3 and 0.5 milliamps, and a brisk motor response of the quadriceps muscle should still be present. This ensures correct needle placement deep to the iliaca fascia, but it does not assure accurate catheter placement. It is essential not to inject any local anesthetic agent or other electrically conductive fluid, such as normal saline, through the needle at this point, since this will render stimulating catheter placement impossible. The notion of opening up the space with normal saline to advance the catheter is not based on scientific fact, since in live tissue it only infiltrates the tissue, makes it edematous, and makes further nerve stimulation impossible or very difficult. This recording shows perfect quadriceps contractions at a nerve stimulation output setting of 0.42 milliamps. The needle is now perfectly placed. Attach the nerve stimulator to the proximal end of the stimulating catheter. Place this part of the catheter in the palm of the left hand, and with the right hand, hold the catheter in the area of the broad black mark, which is 10 centimeters from the catheter tip. Insert the catheter tip into the shaft of the needle. The motor response will immediately start again, and the broad black mark on the catheter indicates that the catheter tip is situated at the tip of the needle, but it is not yet protruding from the needle tip. The needle should never be manipulated if this broad black mark is not completely visible. In the case of this demonstration, the muscle twitches continue at a nerve stimulator output of 0.42 milliamps during catheter advancement. This indicates that the catheter is following the nerve, and this assures correct catheter placement. If, however, the twitches disappear, carefully withdraw the catheter to inside the needle shaft again, such that the entire broad black mark is visible again. Make a small adjustment to the needle by rotating it 1/4 turn clockwise or counterclockwise, or by withdrawing or advancing the needle slightly and again advance the catheter. Repeat this maneuver as many times as is necessary to ensure correct and accurate catheter placement and successful secondary block. In young, healthy, fit adults, this may require many attempts, and patience is usually required. If the catheter is placed without quadriceps stimulation during catheter advancement, it simply means that the catheter is not on or near the nerve, and the block cannot be expected to be successful. If required, the catheter can be advanced until adduction of the thigh due to obturator nerve stimulation is observed, but this maneuver is usually not necessary since the spread of local anesthetic agent will be cephalate along the femoral nerve if the catheter is properly placed. Remove the needle without disturbing the catheter. The catheter is tunneled by first inserting the inner stylet of the needle 1 to 2 millimeters from the catheter exit site if a skin bridge is required, and advancing it subcutaneously to a point approximately 8 to 10 centimeters laterally if this is appropriate for the surgery. This area has previously been anesthetized. The skin bridge will make removing of the catheter easier, but this has to be balanced against a higher frequency of leakage of the catheter. The needle is railroaded retrogradely over the stylet is removed, and the catheter is fed through the needle and the needle removed. The piece of silicone tubing that protected the catheter tip while packaged is handy to place in the loop made by the catheter to protect the skin under the skin bridge. The snap lock is attached to the proximal end of the catheter. The nerve stimulator is clipped to the snap lock, and the nerve stimulation is set to an output of 0 milliamps. The nerve stimulator output is turned up slowly until a quadriceps muscle twitch can just be seen. Local anesthetic agent, or as in this demonstration, normal saline, is injected and the motor response immediately stops. This constitutes a positive Raj test, which is a further indication that the secondary block will be successful. The catheter and snap lock is placed in the stab lock, which is placed in a convenient position, usually on the patient's abdomen. Catheter removal is a sterile procedure and is after the patient does not require the continuous nerve block any longer and after full sensation has returned to the leg. The proximal end of the catheter is fixated with the left hand, and the distal end is removed from the skin bridge. This part of the catheter is kept sterile, and the rest of the catheter is removed.